Hi, my name is Randy Chesnut. I'm a professor of neurotrauma at the University of Washington Medical Center, Harborview Medical Center in Seattle, Washington. I was also the principal author on the best trip trial of ICP monitoring, which caused a lot of Sturm and Drang for a few years. But now that it's been out for a few years, I would like to discuss some of its implications for global neurotrauma management outside of those that caused all the consternation among academic centers. Now, traditional treatment of traumatic brain injury is to put an ICP monitor in and use various agents of varying risk-benefit ratios to hammer on the ICP until one of two things happens. Either the ICP stays less than 20, assuming the patient survives your treatment, or you get so frustrated that you simply take the bone off and rewrite the Monroe-Kelly doctrine. Now that seems a very simplistic way of treating a very sophisticated organ. So what did the best trip trial teach us about traumatic brain injury? Well, from the ivory tower, for academic practitioners and high-resource centers, the best trip trial was all about whether ICP monitoring should be routinely practiced in severe traumatic brain injury. That's what it was about. Do you put a monitor on everybody, and should that happen at all centers? Now, this group of practitioners has minimal or no resource restrictions, adopts new technology early, and has access to monitors and treatments not generally widely available. This is also the group that publishes. So this is what you see in the literature that biases not only the interpretation of studies like the best trip trial, but indeed sets the tone for all publications, the academic orientation of those that write. But what proportion of the global severe traumatic brain injury population will be managed by academics? Really a vanishingly small percentage, since many portions of the world don't have academic centers, and even high-resource centers don't have a lot of academic neurotrauma specialist sites to send all of these patients to. So in truth, the academic centers represent only a small portion of severe traumatic brain injury patients. And even in high-income countries, the majority of brain injury patients are managed without ICP monitoring. An analysis of the TQIP data from U.S. trauma centers by Aziz Alali suggested that only 17.6% of patients meeting the Brain Trauma Foundation guidelines indicating monitoring were actually monitored, a remarkably low percentage in a high-resource country like the United States, suggesting that the proportion of global severe traumatic brain injury patients that are monitored, available or not, is actually strikingly low. But on a global sense, what were the implications of the best trip trial outside of just the argument about ICP monitoring? Well, let's look carefully at the best trip trial, because it was not a trial of ICP monitoring. It was a trial of two protocols, one of which was based on a common algorithm using ICP monitoring, and the other of which was based on an algorithm done in the absence of ICP monitoring, based on imaging and clinical examination. And as you know, in the study cohort, the outcomes between those two groups were the same. Now, what's the implication of that? Well, actually, I believe that the most important implication is that you can achieve good outcomes in the majority of severe traumatic brain injury patients without ICP monitoring. A message of hope for the vast majority of the world where ICP monitoring may not be available. Our principal investigators from the best trip trial expressed exactly that. At the end of the trial, they uniformly stated that they felt, I don't know if the right word is vindicated, but they felt supported by the evidence that what they were doing with so much effort was making a difference in traumatic brain injury, and that they weren't, quote unquote, failing simply because they didn't have an expensive monitor. That's a message of hope. That, I think, is the primary interpretation of the best trip trial, but that's not the one represented in the literature. The one represented in the literature is how the heck could that study not have shown that ICP monitoring, our favorite toy, didn't make a big difference? Well, there are three critical implications of the best trip trial. One is the percentage of severe traumatic brain injury patients in whom strict ICP control is necessary to improve outcome is small. Two is that there may not be an actual critical ICP threshold. And three, the primary question to ask when facing a patient is, what does an ICP of X, 25 or 22 or whatever, mean to this patient? I'm going to address these in these 3 short talks. I'm going to address first the first one, the percentage of severe traumatic brain injury patients in whom strict ICP control is necessary to improve outcome is small. When you look at the spectrum of severe traumatic brain injury, that being the definition, the common definition that all patients who came in with a GCS less than or equal to 8, comatose, when you look at that population, it's fairly large. Now, that is exactly the cohort studied in the BEST TRIP trial. That group was randomized into the 2 groups, not selected on the presence of intracranial hypertension, but selected on the basis of their admission exam. Now, one thing we know is that all of those patients will benefit from good critical care, and that was reinforced in the BEST TRIP trial. But let's talk about intracranial hypertension. So when we look at this entire spectrum of comatose patients, there will be a fair number of them who do not have intracranial hypertension. Now, the big mistake is to equate intracranial hypertension with brain injury, because they're not the same. And it doesn't mean that if you don't have intracranial hypertension, you don't have a severe brain injury. But many of them who do come in comatose don't have intracranial hypertension and will not benefit from ICP management. In these, ICP monitoring is not necessary. I don't know. It may be useful to avoid overtreatment, because we may be treating these patients for intracranial hypertension if we don't have monitoring and they don't benefit from it, and then therefore we're exposing them to the risks of treatment without the benefit. They may need other treatments. We're not exactly sure what they are. It may be that they have cerebral hypoxia. It may be that they have spreading depression. It may be other things that hopefully we will come to an understanding of. But right now, it isn't based on ICP. So then let's look at the patients with ICP elevation, the subset. And these are patients we should monitor. But the truth is that when we talk about absolute thresholds, there will be a group of patients who has mild intracranial hypertension who do not need treatment and therefore won't benefit from it. These are patients in whom the brain is swollen a bit. It's not a problem for the brain. We may not like the number, but the brain is okay with it. And unless we hurt them in treatment or give them a secondary insult like hypoxia or hypertension, they should do fine. There's also a group of severe injury where the intracranial hypertension is merely a sign of the severity of disease, and ICP treatment does not produce a good outcome. The Rescue ICP trial showed that. They took a very severely injured group of patients and treated them very aggressively. Their good outcomes were not good or moderate on the GOS-E. They were severe disability, upper severe, which is survival, and they tend to improve over time, but it's not a great outcome. And it's because the primary injury, the primary brain injury, was so severe that even management of this difficult intracranial hypertension did not reverse the primary injury. So now we're left with patients where ICP treatment will make the difference between good and outcome. These are the ones where if we treat them with ICP management, they will do better than if we don't. The difference between good and poor outcome. These are patients, obviously, we must monitor. But it's a relatively small subgroup of severe traumatic brain injury. And there's a question is how we detect this group. And to be honest, we probably can't currently. We can probably detect a somewhat larger group based on imaging, based on maybe non-invasive monitoring, etc. We'll probably select a group that includes some who actually don't need management of their moderate intracranial hypertension, in which case we will overtreat them to correct the number to that with which we're comfortable. And there will be a group in which our treatment will be ineffective, and we may spend a lot of resources on that group, but we can't identify them, and they will have intracranial hypertension. And the truth is that once we identify this group that has intracranial hypertension, it's probably best that the next step is to use multimodality monitoring to determine why the ICP is elevated. Because we know there are a lot of reasons why the intracranial pressure can be elevated. They're not all the same, and they don't respond to the same treatments. For instance, temperature-related hyperemia is not well treated by mannitol. It's better treated with antipyrexics. So it's not just that this group will benefit from intracranial pressure monitoring, but this is the group in which we probably need to better target the method of lowering the elevated ICP. The next talk will be on point number 2, whether or not there is an actual critical ICP threshold. That will come in part 2 of this series. Thank you.